Thank you, Dr. Chow. As mentioned, my name is Muizz, and I'll be presenting on the echocardiographic assessment of constrictive pericarditis. Oops. So starting off with the outline of my talk, we'll go over some background and historical context. We'll go over an overview of hemodynamics, as well as then the echocardiographic diagnosis of constrictive pericarditis, focusing on a paper by Welch et al., which was published in 2014. And then we'll finally differentiate constrictive pericarditis from other similar pathologies, mainly restrictive cardiomyopathy and decompensated ventricular failure, which can have some overlap when it comes to figuring out what's going on. With constrictive pericarditis, it's a chronic inflammatory process of the pericardium that causes fibrotic thickening, scarring, and calcification. This can be caused due to several different reasons, one of which could just be idiopathic. Otherwise, other common causes are post-surgical, post-radiotherapy. In countries where tuberculosis is prevalent, it can be related to TB pericarditis, and of course, any other causes of acute pericarditis, specifically if they're recurrent or relapsing. Giving some historical background, this lady over here is Dr. Liv Hatle, who's a Norwegian cardiologist, who was a pioneer in Doppler echocardiography, lived between 1936 and 2023, so really only passed away a couple of years ago. She was heavily involved in the advancement of non-invasive diagnosis of constrictive pericarditis, and specifically differentiating it from related conditions, mainly restrictive cardiomyopathy. Of course, she'll have her own sign when it comes to this diagnosis, but you'll have to stay tuned for that. Next, we'll go over some basic hemodynamics related to constrictive pericarditis. Constrictive pericarditis, as we mentioned, occurs when the pericardium becomes a stiff shell around the cardiac chambers. This causes a variety of consequences, including equalization of pressures of all four cardiac chambers, with the pericardial pressure predominantly in diastole. There's a dissociation of intracardiac and intrathoracic pressures. And then, of course, we have ventricular interdependence. We'll take a deeper dive into some of the hemodynamics by looking at some right and left heart cath tracings. Now, it's not echo yet, but understanding hemodynamics helps us understand what we're looking at during our echo assessment. The blue tracing is a right atrial pressure tracing, and black is a left ventricular tracing. For the RA pressure tracing, the A represents atrial contraction. The X is atrial relaxation with pulling of the tricuspid annulus down during ventricular systole. The V is atrial filling during ventricular systole, and the Y is atrial emptying. A classic finding in constrictive pericarditis is rapid X and Y descents with an overall high mean right atrial pressure. The steep X descent represents rapid relaxation and generation of negative pressure as the tricuspid annulus is pulled down to allow for rapid filling of the ventricle before it's constrained by the stiff pericardium. Similarly, I guess it's not really.
It's not synchronized, yeah.
Okay. Similarly, steep Y descent indicates rapid ventricular filling with high atrial pressures. There is an abrupt halt mid-diastole when pericardial constraints are reached. The LV tracing shows a classic square root sign and dip, or dip and plateau, indicating the rapid filling during early diastole until it reaches pericardial constraints, creating an abrupt rise and halt in pressures. Now, how our cardiac chambers react during respiration is the most important concept to understand when it comes to understanding constrictive pericarditis. With constrictive pericarditis, there's dissociation of intrathoracic pressure and intracardiac chambers. What that means is that with inspiration, there is decreased intrathoracic pressures or pressures within our chest that are transmitted to the pulmonary veins, but not to the but not to the cardiac chambers. Because of this, there's decreased flow from the pulmonary veins to the left atrium due to this decreased pressure gradient, and subsequently from the left atrium to the left ventricle. Because of this decreased filling to the left side of the heart, the septum is sucked to the left, increasing right ventricular volume and flow from the right atrium and the IVC. Overall, the right ventricular pressures are increased and the left ventricular pressures are decreased. With regards to the SVC, it is an intrathoracic structure, so its pressures are decreased, which creates a decreased gradient from the SVC to RA, so flow is decreased, and this actually results in a positive Cosmal sign, which is what we see. Now, I did want to bring up the issue of tamponade because it is somewhat of a similar physiology, but it is different in some ways. So with tamponade, there isn't a stiff shell around the heart, so there actually isn't dissociation of intrathoracic and intracardiac pressures. Because of this, with inspiration, there is increased filling of the right heart and the right ventricle expands, pushing the septum to the left, and this decreases filling of the left ventricle. Because of this, you don't actually get a positive Kussmaul sign because the right atrial pressure and the JVP decreases with inspiration. Now, during expiration, you get the opposite happening. So with expiration, you get increased intrathoracic pressures, which are transmitted to the pulmonary veins, but not to the cardiac chambers. This increased flow is seen as blood moving from the pulmonary veins to the left atrium due to this gradient, and then subsequently from the left atrium to the left ventricle. This increased filling of the left side then pushes the septum to the right, decreasing right ventricular volume and flow. And flow from the SVC, however, is preserved as, again, it's an intrathoracic structure that sees this increased pressure during expiration. Overall, right ventricular systolic pressures during expiration are decreased and left ventricular pressures are increased. Now, this is a right and left heart cath looking at right ventricular and left ventricular simultaneous pressure tracings. Looking at the area under the curve, we can appreciate ventricular interdependence. With inspiration, so inspiration going this way, we can see that the pressures within the right ventricle increase and the pressures within the left ventricle decrease. If we again look at the areas under the curve, and then with expiration, so this section over here, we can see the opposite happening. The left ventricle area under the curve increases and the area under the right ventricular tracing decreases. Next, we're going to talk about an important paper by Walsh et al. And go over echocardiographic criteria they studied in the diagnosis of constrictive pericarditis. Within their study, they looked at 130 patients with constrictive pericarditis and 36 patients with similar non-constrictive pericarditis disease, namely restrictive disease and tricuspid regurgitation. This was between January 2008 and December 2010. They used 2D echo, Doppler, and tissue Doppler with simultaneous respiratory recording in their study. The echocardiographic variables that they examined were fivefold. So respiration-related ventricular septal shift, the variation in mitral inflow E velocity, the medial mitral annular E prime velocity, the ratio of the mitral annular E prime to lateral E prime, or known as annulus reversus, and then the hepatic vein expiratory diastolic reversal ratio. With regards to ventricular septal shift, it's considered the cyclic septal movement, and namely a shift towards the left ventricle of the septum during inspiration. This happens many times, and we see it as this strange septal movement, again, that varies with respiration. This sign itself was present in 93% of patients with constrictive pericarditis, and so it really is considered the most sensitive parameter out of all of these variables that they looked at. The best way to appreciate this on echo is by using an M mode through the septum with a respirometer attached. We can see that with inspiration, as the curve is moving up, that the RV cavity increases in volume, the septum is shifted to the left, and then the volume in the left ventricle decreases. The opposite happens with expiration, where the volume in the right ventricle decreases, the septum is shifted towards the right, and then the left ventricular volume has increased due to the hemodynamics that we talked about earlier. Next, we'll talk about mitral E velocity variation. This is looking at how early diastolic flow through the mitral valve changes with respiration. The way that we calculate this is by looking at our E velocities at expiration and inspiration, and the calculation always remains the same. So we look at our velocity in expiration minus inspiration over expiration times 100 to get a percentage. The average change in constrictive pericarditis was 30.7% plus minus 20.4%. And in other cases, it was 13.7% plus minus 17%. In their study, the optimal cutoff point that they use in terms of optimizing both the sensitivity and specificity of this variable was a change in 14.6%. This seems somewhat low. In other studies, they've identified higher E velocity variations, upwards of 25 to even 40%. And it seems like it's generally accepted to consider 25% as positive for constrictive pericarditis. And I just want to reiterate that this should be expiration, just so it's not lost. This is what we're looking at when we're looking at our E velocity. So essentially, we have a pulse wave Doppler recording through or at the mitral valve tips. And of course, we want to have our respirometer attached to look at inspiration and expiration. There are 2 points here. Now, this picture over here chooses this point as inspiration. Personally, I may have chosen this point here. It seems like it's the lowest velocity here, but maybe Dr. Chow can.
The next one, right?
Oh, I see. Yeah.
Typically, we choose the lowest one and the highest one,
right?
As a combination, because there's often a phase lag in the inspiration and the expiration phase. But obviously, having the respirometer is really important.
Right.
Yeah.
So we can see that our expiration is here, inspiration is here, and using our calculation, we get a value in terms of the variation change. The next variable that they looked at was the medial mitral annular E prime velocity. This is looking at a measurement via the tissue Doppler at the medial annulus. The mean E prime that in the study that they saw was 12.9 centimeters per second in constrictive pericarditis versus 7 centimeters per second in non-constrictive pericarditis. The optimal cut point that they chose with constrictive pericarditis was more than or equal to 9 centimeters per second, as having a strong association with constrictive pericarditis. So with regards to the conceptually, generally the lateral E prime is, and then, sorry, just similarly related, we'll talk about the medial and lateral E prime ratio or annulus reversus, which is related to the last variable. So generally the lateral E prime is higher than the medial E prime. In constrictive pericarditis, the thickened pericardium restricts the movement of the lateral annulus because it becomes tethered to the pericardium. This results in the medial E prime to be equal or greater than the lateral E prime, where as in normal cases, it's flipped. The ratio that they found with constrictive pericarditis was 1.2 versus 0.8 in non-constrictive pericarditis. And the optimal cut point that they found in terms of optimizing the sensitivity and specificity was greater than or equal to 0.9. Now, this is what it looks like with our tissue Doppler. We have our medial E prime on the left and our lateral E prime on the right. We can see that this is somewhat the opposite of what we expect in non-constrictive pericarditis cases, where the lateral E prime is lower than our medial E prime. And again, we can use the ratio, and if it is greater than or equal to 0.9, it's specific for constrictive pericarditis. The last variable that we'll talk about is the hepatic vein expiratory diastolic reversal ratio. So I'll actually show the picture first. So this is, again, using a pulse wave Doppler at the hepatic vein to look at flow during systole and diastole. We can see here that again, with the respirometer attached, we can see how flow varies with both inspiration and expiration. With expiration, we can see that diastolic flow is increased, where forward flow, diastolic flow is reversed in diastole, and the ratio between flow just going back here. The ratio with the diastolic reversal velocity divided by our forward velocity and expiration, if it is higher than 0.79, is a highly specific sign for constrictive pericarditis, or at least by 88%. With isolated severe TR, hepatic vein flow reversal does occur, but it occurs during systole, so that's one way to differentiate it. So we can see here that, again, we take this ratio to this, and if it's greater than or equal to 0.79, then it becomes a specific finding for constrictive pericarditis. These are looking at the sensitivity and specificity of the individual variables that we looked at. For the most part, these are fairly sensitive and more so specific tests, even on their own. Of course, you can't really make the diagnosis of constrictive pericarditis with just one of these variables, which is why they also looked at the combination of these different variables. Now, of course, for the most part, you'll be doing a lot of these in your regular echocardiographic assessments anyways. The calculations can come at the end, so they aren't necessarily any extra steps. So for the most part, you'll have most of these variables already, and looking at them all together will help increase, namely, the specificity of the diagnosis when it comes to constrictive pericarditis, which is why it's important to have all of the information when we're concerned about this disease process. The other thing we need to consider is the presence of atrial fibrillation or flutter in the diagnosis of constrictive pericarditis using these same criteria. Looking at the p-values, we can see for the most part these are all fairly significant and would be useful in distinguishing constrictive pericarditis. However, one does stick out, and that's the percent change in the mitral E velocity. So we can't really rely on that variable when it comes to considering constrictive pericarditis for patients with fibrillation or flutter, but we can rely on everything else. Additional echocardiographic findings that they looked at on the paper were pericardial thickening, which seems to be, of course, present in most cases with constrictive pericarditis, or at least 85%. The concept of right ventricular free wall tethering, which is also seen in 61% of cases of constrictive pericarditis, and ventricular contour distortion, namely, again, related to how constrained the cardiac chambers are within the thickened pericardium. And again, this is a specific finding, but only in 34% of cases with constrictive pericarditis. Next, we'll talk about differentiating constrictive pericarditis with restrictive cardiomyopathy and ventricular failure. With restrictive cardiomyopathy, there's poor relaxation and poor compliance, but preserved systolic function. The non-compliant myocardium acts as a shell that causes the same increased right and left diastolic pressures. The ventricular dip and plateau pattern that we talked about, which relates to the early filling and early halt of filling due to the pericardial constraints, and then the deep and rapid X and Y descents, and that's, again, namely for restrictive cardiomyopathy. With severe ventricular failure, we have severely reduced ventricular compliance and stretching of the pericardium by the dilated ventricle. And in that sense, it's functionally constrictive. Rapid volume expansion causes equalization of the right and left-sided diastolic pressures. Now, this table looks at some of the differences between these disease states. So starting off with the first point, so equalization of the right ventricle and left ventricular end diastolic pressures during inspiration. So we do get diastolic pressures that are fairly close in restrictive cardiomyopathy, but they will differentiate by more than 5 millimeters mercury. The wedge pressure and the RA pressure are also unequal, with the wedge pressure being higher than the RA pressure. However, something to note is that the more severe your right ventricular failure gets, the more likely you can get left ventricular and right ventricular diastolic equalization. The other thing to consider is essentially the second point is talking about Kussmaul sign. So with constrictive pericarditis, you don't get an increase or you may even get, or you don't get an increase in your mean right atrial pressure with inspiration. With restrictive cardiomyopathy, your, as we mentioned, your intrathoracic and intracardiac chambers are still associated, so it will see the negative pressures when you inspire. As a result, you don't get the Kussmaul sign. With severe RV failure, you actually do get a positive Kussmaul sign because you the inspiratory increase in RA pressure can be seen with severe disease. The other thing to consider is the early diastolic gradient between your wedge, which is your left atrial pressure surrogate, and your left ventricular pressure, which can vary with respiration by more than 5 millimeters mercury. That's essentially talking about the early filling of the left ventricle due to these higher pressure gradients. There isn't that significant early diastolic gradient with the other disease states. The other thing to consider is this concept that we talked about with the ventricular interdependence or the discordant systolic peak LV and RV pressures during respiration. Whereas in a restrictive cardiomyopathy and severe ventricular failure, there is concordant changes. And then finally, the last 2 points. So systolic PA or pulmonary arterial pressure is usually less than 55 millimeters mercury, where it's usually higher than 55 millimeters mercury in the other disease states. And then when we look at the pressure gradient of the right ventricular end diastolic pressure and the right ventricular systolic pressure, it's usually more than 1/3 in constrictive pericarditis, where it's less than 1/3 in restrictive cardiomyopathy. And again, the more severe your right ventricular failure is, it can occasionally reach more than 1/3, but again, it's usually in the more extreme cases in those instances. Now, these are again looking at a yes, yeah.
Thank you, Amin.
Now, this is, again, a right and left heart cath. We saw one of these before, and one of them is new. So looking at this, I don't know if someone wants to jump in and tell me which one's constriction and which one is not.
Yeah.
So yeah, A is constriction, and that's because we do see that the RV and LV pressure tracings are discordant with inspiration or with respiration. So we can see that the RV area under the curve increases with inspiration, the LV decreases, and vice versa. These are more concordant changes, so we can see that with inspiration, the area within the RV and the LV both decrease, and again, vice versa. So this is what we expect to see with for example, restrictive cardiomyopathy. So another way to differentiate constrictive pericarditis and specifically restrictive cardiomyopathy is through echo, and that's using our hepatic vein flow with respiration. Just as a reminder, the S corresponds to systolic flow, which corresponds to the X descent on the right atrial tracing or atrial relaxation. The D flow or diastolic flow corresponds to our Y descent or atrial emptying, and our A reversal is essentially our atrial contraction. As mentioned, we have diastolic flow reversal with expiration with constrictive pericarditis. With restriction, the right atrium is poorly compliant with outward pressures, which allows for less forward flow during ventricular systole. And really, we only get significant flow during diastole, as we can see here. And again, there isn't any respiratory variation with restrictive cardiomyopathy. This looks at flow from the pulmonary vein into the left atrium. With expiration, we increase flow towards the left heart for all the reasons that we talked about. This is actually considered the Leave-Hatley sign, where we get this increased flow in expiration. And this is due to increased pressure gradient between the wedge or the left, between the pulmonary vein and the left atrium. And then with respiration, we can see that again, there isn't any respiratory variation, and our predominant flow occurs during diastole. And then with regards to some echocardiographic differentiation between constrictive pericarditis and restrictive cardiomyopathy, you can see that there are a few similarities. Our E/A ratio is often more than 1.5. Our decel time is reduced in both states. The ventricular size and systolic function are generally normal, and our atria, again, can be dilated in constrictive pericarditis, markedly more dilated in constrictive cardiomyopathy, but not necessarily a good distinguishing feature. This is, again, a table that sort of summarizes more of the more notable differences that we see in both of these disease states. So as mentioned, the respiratory E variation, for the most part, we use the cutoff of greater than 25%, though, as we noted on the other paper, even using 15% can be fairly specific. You don't, of course, see that with restrictive cardiomyopathy. Again, our medial annular E velocity greater than 10 with constriction, less than 10 with restriction. Our hepatic vein pattern varies with inspiration, and the systolic flow is more predominant than diastolic flow, which is the opposite with restriction. Similarly, with our pulmonary venous flow, we get changes with respiration and increased flow during expiration, whereas there's no variation with respiration, or minimal variation, I should say, with restriction. Now, this is not something we look at, so I'm just going to ignore it. But essentially, it's looking at the flow from the mitral valve to the apex of the LV, but it's not something we normally measure. And then, again, our abnormal septal motion, looking at the M mode on 2D echo, we can see that septal bounce that we're fairly familiar with in constriction, whereas you don't get those changes with restriction. And again, this is looking at the sort of early filling and early expansion with this abrupt halt in filling due to constrained pericardium. This is done by using the M mode, again, with our long axis. And we can essentially see how the posterior wall moves, and it's kind of equivalent to the dip and plateau sign that we see with our left and right cap. And then again, we can measure our PA pressures, and then looking at TR and MR, which seems to be more frequent with restriction. With severe RV failure, our last point that I just want to talk about is that it can mimic constrictive pericarditis, especially with more severe disease. And as we sort of alluded to, there can be even more overlap the more severe your RV failure is, as the pericardium becomes more and more functionally restrictive with the extensive RV distension. Because of this, we can get a very deep, wide ascent due to this rapid early diastolic filling. And this is because you have persistently high right atrial pressures and tricuspid regurgitation. And again, all this filling is occurring in a fairly non-compliant and stretched right ventricle. We also get a large diastolic deflow on our hepatic vein Doppler. Again, some overlap that we see with constriction. The differences that we see, though, are you rarely cause any discordant LV or RV pressures with respiration. The RV is markedly stretched, as you can see over here. So even with inspiration, it's very difficult at a certain point for the RV to continue to stretch or fill up with blood. Although we get a deep, wide ascent for right atrial emptying, we don't really see the same deep X or atrial relaxation, and that's usually because with severe RV failure, we have very bad tricuspid regurgitation and large V waves. And then finally, unlike in constriction, your right-sided pressures can exceed the left-sided pressures with inspiration due to how bad your RV failure is. But again, that's not something we generally appreciate with constriction. I believe that's pretty much it. So this is just a summary of everything that we talked about. Won't really go through it. It's really a slide from the ESC, but again, goes over essentially all of our points. It's kind of it. These are some of the references that I used. And if you have any questions, happy to take them.